Welcome to the show discussing problems and issues of health with Dr. Alcena. For this segment of the show, I'm going to continue to talk about hypertension. Hypertension is a serious medical problem. Worldwide, there are 1.5 billion folks with hypertension, and in this country, you have 76 million folks with hypertension and 67 million folks with the so-called prehypertension, which has to be taken into context because if somebody has diabetes mellitus or they have sickle cell disease, they're prone to have kidney disease that live long enough. So therefore, blood pressure that's considered normal in individuals who don't have this problem is in fact too high in people who have hypertension, who have diabetes and sickle cell disease, because we want to do all we can to protect the kidneys best we can. Now, and also it is clear that it ought to be said that in this country, 1 out of every 3 adults has hypertension, and 1 out of every 2 black adults has hypertension. Very, very common problem. And last week I went over the concept as to what type of medication ought to be used to treat hypertension. And of course, I mentioned the thiazide diuretics, which cost $7 for 30 pills per month, is the cheapest blood pressure pill, and yet it is the most effective because the genesis for hypertension is salt retention, and you need the thiazide diuretic to remove the salt and the water out of the body in order to control the blood pressure. Now, before I proceed, I want to again share with you this book that I wrote, The Art and Practice of Modern Clinical Medicine. It's 136 chapters, 889 pages. I wrote it all by myself, just about from the top of my head, except for looking up a few statistics here and there. And it is a fantastic book. If it is really high-powered, the latest clinical medicine that you're really interested in as far as the 21st century is concerned, you have to get your hand on this book. I don't care whether you're a physician, a medical student, intern and resident, nurse practitioners, PA, or whatever. This book will be extremely valuable to you. The book, I'm sure, can be found in your local public libraries as well as wherever books are sold. And of course, there are always a few copies to be found in my office as well. Now, last week I talked about the ACE inhibitors, why they shouldn't be used in non-Caucasian individuals, because the mechanism through which they work is to lower renin, and all non-Caucasian folks, no matter what part of the world they live in, they have low renin. And so for what's the point? The renin is low. There's not enough renin to lower the blood pressure. And so I spoke about the ARB, which is angiotensin receptor blocker. The ARBs are perfect for lowering blood pressure in all individuals, regardless of their ethnicity, because the ARB blocks the entire renin, angiotensin, aldosterone pathway from the very beginning to the very end. And nowadays, there are combinations of blood pressure pills that have an ARB plus a thiazide attached to it, thiazide diuretic attached to it, and that's even better because when an individual can take 1 pill per day instead of 2. It's fantastic. Now, in this segment, I want to talk a little bit more about a different family of medication that are in use to treat blood pressure, namely the calcium channel blockers. Well, in order for any muscle in the human body to contract, like if I contract my arm like that, I need calcium to allow the muscle to do that. Well, that being the case, many, many years ago, the scientific people went into the lab. They figured out in order to block the action of calcium to contract, they created this so-called medication, calcium channel blocker, which they block the action of calcium, therefore the muscle relaxes. And these medications were originally created to treat angina pectoris, so that the coronary vessel can relax, open up to allow blood flow to go through. It turns out that a side effect of those medications were then observed that the people's blood pressure were being brought down. And nowadays, almost 100% of the time, these medications are used to treat blood pressure. They're marketed as such. they're made as such for that reason now. Other things are done to treat angina, and but not the not the calcium channel blockers. If somebody happens to be on a calcium channel blocker, and that's an extra advantage for whatever reason we put them on, and they also happen to have coronary occlusive disease. Now, I'll name some of them for you, and now you understand how it works. They just block the action of calcium that's inside the muscle. As because of that, the muscle relaxes, and of course, the wall of blood vessels. You can't have a blood vessel without having calcium in the wall of it as part of the muscle. So once you relax that, then the relaxation of this muscle causes the pressure to go down. Okay, that's how it works. Now, I'll name some of them for you: verapamil, cadazim, CD, Vasotex, Procardia, Adalat, Caduet, and there are, of course, many more of them out there. Now, this is how they work. And you, again, must understand that you cannot use them by themselves to treat the blood pressure. You can, but for you to do so, you would have to be in a completely total salt-free diet. I'm talking about maybe a gram of salt per day, which most people cannot tolerate because the food is very unpalatable. It's not very tasty when you have that little salt in it. You have to understand that the average, the median consumption of salt in black folks in this country is 7 grams. That's ridiculous, but that's the diet. How did that get to be? Well, I don't want to take off on the tangent explaining to you how black folks happen to eat a food that is so salty. It isn't because they wanted to eat that way. This was forced upon them. It was forced upon them because during slavery time, the masters and the wives and whatever children were eating the best food, and they leave the crumble off the table for the slave. Well, in order to survive, they came up with the so-called soul food. People don't even understand how that happened. It happened because you have to understand there was no refrigeration. So the best way to cure a meat so it doesn't become rotten was to season it with salt, heavy-duty salt, a lot of lime juice, and then cure it that way, and then put it pretty much on a rope in the sun so it could dry it out. This way they can eat a piece of it at a time, and it doesn't get, because they didn't have refrigeration. That's what they come up with. So this way the food, whatever they were, if they had to do, they become very salty. In addition to that, to make the food tastier, they come up with all sorts of spices that they had access to, and they cook up the food with the heavy-duty salt, a lot of spice. Obviously, they were using lard, which is the worst type of fat that you could come up with. I know that because I was not a slave, but when I lived in Haiti, I was almost living in a slave situation, even though I was really not controlled by anybody. But that's how the folks cook the food. That's how they cook the food, and that's the food that I had to eat, which was lifesaver for me, frankly. And then you have to understand, I survived mostly on grits and beans and stuff like that, because rice and chicken, those things were delicacies that people would use cook on Sunday. Well, I didn't have access to those things, so the stuff that I'm talking to you about, as I was watching this morning a show on television, and the red nose thing, develop recruiting money for poor children across the world. Well, I have not come in contact with a child that was as poor as I was, even though I was born to a rich mother who unfortunately lost her life when she was about 37 or so, giving birth to a child. So suddenly my world crumbled, and I was in the most. You think Haiti is bad now in terms of poverty. When I was born, Haiti was not bad in terms of poverty, but I was. Okay, I mean Haiti was doing great at the time when I was growing up, except that I didn't benefit from that because I was living in a peasantry, working in the farm since I was about 9.5 years old, for $1 per week, which was 20 cents a day, from 8 o'clock in the morning until 5 in the hot sun, barefooted, no clothes on my back. Okay, and that's my experience. And, you know, that's okay. But God also knew what he was doing. He took all these folks away from me, but he gave me a brain. And I knew that. You didn't have to tell me that I was intelligent. I knew that because my mother told me. Since I was 5 years old, she put me in first grade, and I was a star in the school. That's all I had. Everybody else that I knew had everything as far as I was concerned, but I had the brain. So, and I did everything I could throughout this world to find myself in a place where the brain can help me. And this is this country. That's why I owe so much to this country. Somehow, through the help of God, I worked very, very hard to find my way here. And I won't go into the detail, but I did. And this is the result. So therefore, I know a lot about the stuff that I'm talking about, the stuff that I actually experienced, not just theoretical stuff you read in a book. I experienced those things. So therefore, then, you just simply, this is how folks had to survive. They ate what they had access to, and they were very innovative. They created all these different ways of preparing the food so the food can be tasty. All right? So, but you cannot, in this modern era, find people have food that a lot of spice, a lot of grease, and so on and so forth. But nevertheless, the black community still have the habit because food is cultural. It is cultural. Eat you eat food that your folks fed you when you were growing up. It couldn't care less whether you become a multi-trillionaire. You still crave for the food that you were brought up on when you were a kid. That's the way it is. It's genetic and it's cultural, etc. Okay, so you have rich people now, super rich, in the black community. They still go home to have the grits. Yeah, have the grits and the beans because that's what they like. They'll go in all this fancy hotel and eat whatever folks feed them, but they can hardly wait to get home so that they can have the food that they're accustomed to. That's just the way the world is. That's just the way human race is. So therefore, you can use one of these. Let me give you an example. Let's say, for instance, you were to use any one of these calcium channel blockers to lower the blood pressure, which you can. If you use the quantity large enough, it will drop the blood pressure. But the kidney is not stupid, because the kidney's job, in addition to all the stuff that it produces and all the stuff that it does to get rid of the waste material, the kidney also is there to protect the body. When the kidney senses that the blood pressure is dropping or has dropped, what do you think the kidney is going to do? The kidney is to clamp down, hold on to salt, to hold on to water in order to protect the body. And a classic example of that, somebody can show up in the emergency room they found the person in shock or whatever and brought them to the emergency room and will put a Foley catheter in and the kidney tests come back abnormal. I want to know, if you're a smart doctor, you don't need $1 million machine. You want to know if this kidney abnormalities has failed several months ago, or is the kidney just failed an hour or so ago because of the shock state the person is in? It's simple as getting some urine from the bladder of that person as you put the Foley in and send that urine to the laboratory immediately to examine its salt content. Listen to that. To examine how much salt is in that kidney. Okay? Now you got to listen to this. If what happened to the kidney just happened within hours ago, the salt content of the urine that I just sent to the laboratory is going to be low. Let me repeat that. It's going to be low, which is making the point I'm making. It's going to be low because the kidney is trying to save the body that just went into shock, and the kidney is holding onto the salt, so there's not enough salt coming out of the urine. That's absolutely 100% correct. However, if the salt content in the urine comes back high, I can 100% guarantee you that kidney has failed several weeks or several months ago. Had nothing to do with the immediate shock. That can worsen it, but had nothing to do with it. I mean, you don't need $1 million machine to do this. This is simple. It costs cheap, pennies, to take some urine and send it to the lab while you're doing all the stuff that you would. What's the importance of that? Super important, because when we have somebody that show up in a hospital setting, acutely sick, and the kidney is failing, we have a protocol we have to go through to try to save that kidney. We know how much fluid to give the person intravenously, what type of fluid to give them, while we're taking into consideration what we call insensible loss, which is sweat, water from the stool, water from the. We have to take all that consideration. We know how much fluid to give, how much not to give, and we can predict, pretty much predict, if the kidney is going to recover or not. You can't make this up because this is the truth. So you have to know these things so that we know exactly what's going to happen. So by knowing that the kidney had just failed because the salt content in the urine is low, that allows you, as the clinician at the bedside, to know how to manage the patient's kidney care from here forward. Okay, and the acute failure, which we call acute tubular necrosis, will you know how to manage that. Now this is stuff that you have to learn that to know how to do. You have to have the experience because you could do further damage to the patient, making the kidney worse and may not recover if you don't manage it properly. Now the whole other fancy stuff you could do, those are fancy, that take time to come back, they cost a lot of money. But doing that simple thing, you could set up your treatment protocol and having pretty much guarantee, you know, in 48, 72, 4, 5 days later, the kidney is going to recover because it just failed. Okay? It's an acute shock to the kidney. But if your salt content of the urine is very high, that kidney has been damaged a long time ago, and now that this has happened to it, that's it. That kidney is finished, may not come back, okay? All right? So this is why I'm saying to you that it is very important that you understand you cannot, absolutely cannot build a house without having a proper foundation. You just can't just write prescription and give them to somebody because some drug company says this medication is good for lower blood pressure. Under what set of circumstances are you using it? And then whom are you using? It's very, very important. So the calcium channel blockers are fantastic medication, but you have, because they work in all ethnic group, all, across the board. Across the board. Has nothing to do. We just simply have to know how procardia works. You have to know how cardism works, because if somebody's pulse is already low, you can't give them cardism, because one of the benefits of cardism is that it lowers the pulse, and we use it all the time intravenously to treat somebody who's having an acute ventricular problem. The rate is very, very fast. We could use intravenous. So you have to understand these things. But it's not my job to sit here and teach you these things. You simply have to know them. So not all channel blockers work the same way, but you have to know how to take advantage of them, okay? Now, the next family of medication I want to get into is the so-called alpha blockers. You have the beta blocker, calcium channel blocker, beta blockers, alpha blockers, Hytrin, Cadura, clonidine, Aldomet, Adrenaline. These are so-called alpha blockers. We know when to use them, when not to use them, and in whom to use them, and in whom not to use them. Okay? Again, I'm not here to teach you everything I know. That will never happen, believe me. But I'm here to help you enough so that you understand the concept, what these medications are. You know, the alpha blockers, Hytrin, Cadura, clonidine, Aldomet, Adrenaline. You have to know what they are, how to use them, and what combination to use them, and when to use them. Because some of these things, the alpha blockers tend to make people sleepy, so you use them at night. You give the patient clonidine, let's say, at night when he or she is going to sleep, so that that controls the blood pressure during the night. So when she wakes up in the morning, she wakes up with a baseline blood pressure that's already normal, and then you start her regular medication, and so on and so forth. Okay, again, this is clinical medicine. Okay, you want to learn clinical medicine? Read this book. Okay, now there's not a family of medication that's really extremely controversial. Today, again, in this segment, I'm going to this medication with you. I got plenty of time. I'm in no rush. This is the beauty of this show that I do. It's my show, and it's nobody's show. And they can't push me. They can't tell me what to do, what not to do. I'm the boss here. I can take my time and do everything very thoroughly. Now, let's talk about this most controversial medication, okay? They call it beta blockers. That's one of the key problems in the treatment of hypertension. Physicians all over the world, not just here, because you have to understand the so-called Caucasian model had been infiltrated into medicine throughout the world because America is a leader of just about everything in this world. So if America says something is good, people jump up and do it. Okay, now, beta blockers are outstanding medication. We can't practice medicine without them. Just cannot, because they are that indispensable. They're that good. But problem is, a whole bunch of my colleagues are using them to treat blood pressure by themselves. Cannot do it. You can't. There's no way, absolutely no way that can be justified because it makes no sense. Absolutely zero sense. These medications are fantastic to treat congestive heart failure. They're fantastic to treat cardiac arrhythmias and so on and so forth. We just simply cannot practice medicine without them, honestly, because they're that crucial. As a matter of fact, if somebody shows up in the emergency room with a hypertensive crisis, the first medication we're going to use to save the patient from bleeding into the brain is labetalol, which is a beta blocker. We could give that intravenously, acutely, so long as the patient pulse will allow her to do so. If the pulse is low, you can't do it because the labetalol, one of the side effects of it is going to lower the pulse, so you can't do that. However, the patient pulse is normal, 65 to 80, thereabout. You're going to give them IV labetalol acutely to lower the blood pressure. This way you could do it. That's an intravenous medication that's being used intravenously, acutely in a hypertensive crisis. That is not the same as using a beta blocker every day on the outpatient to treat blood pressure. This is ridiculous. If you do that, then you really don't understand basic physiology. I hate to have to say that because you have to understand something. The possibility, let me explain something. The possibility of a beta blocker lowering somebody's blood pressure by itself on a routine basis, I have to take you back to the adrenal gland. The medulla of the adrenal gland is capable of secreting somewhere around 2 to 3 or 4% likelihood that you could block that little bit to lower somebody's blood. Let me repeat that. It's not absurd. Somewhere between 2 or 3 or 4% max, the substance that is secreting into the bloodstream, that you could take advantage of that to lower blood pressure. For that, you're going to put somebody on a beta blocker all day long, so they feel tired all the time, sleepy all the time, they can't function. It makes no sense. And again, I just want people to understand this is not knowledge that I have monopoly to. I wish I did, then I can copyright it and make $1 trillion because beta blocker is used so great all over the world. But I do not have monopoly to that information. It's all over the place. People that have to get off the you know what and learn this stuff so that then they can understand it. Some of them went through medical school way back, like I did. This is, by the way, this week is my 43rd year since I graduated from Albert Einstein College of Medicine. This is an anniversary for me, May 24th. May 24th, 1973. So I've been on at this. 43 years I've been at this. But because I chose to remain an academic teacher, not to chase the money to build my multi-trillion homes in the suburb, as it were, I constantly kept reading these things so that I can teach them, I can write them, I can lecture them. Because medicine out there is pretty rough. Not criticizing my colleagues. It's a business. It's pretty rough. People have bills to pay, kids to send to college. They're running all over the place. The HMOs are taking all the money for themselves. They're treating us like we are nobodies. In fact, we referred to as providers. We're not physicians. Only time you're a physician if you work for an HMO. Otherwise, we are treated like literally like dirt. They do whatever they want to us. Whatever they want to us. You have no idea what I had to do recently to have my whatever you call that appointment renewed with one of those HMOs. Maybe they get pissed with me or whatever. You can't make this up. I'm not even go there. But They had no reason not to renew me, so they renew me. Okay, but what I had to go through, like I pretended I didn't know what the heck was going on. I'm not stupid. I may be dumb, but I'm not stupid. So they put me through it, everything they wanted, including my. Can you imagine that after being with an HMO for more than 20 something years, this year they wanted a copy of my resume. So I sent them the 30 pages. Okay, what are they going to do with it? I have no idea. In any event, they can't stop me. They can try. Only God can do that. So let me listen to you. If you think I'm just the one saying that, there was a study done called the Ascot study, which is Anglo Scandinavian studies, okay, involving thousands or hundreds of thousands of people, because in England and Scandinavia, the government pays the bill, so therefore they have access to all this information. So they set up this study. Let me tell you what it says, so that you don't understand. So you understand that I'm not just making these things up. I don't make things up. The Ascot Anglo-Scandinavian trial blood pressure lowering arm shows that beta blockers as monotherapy do not work to treat high blood pressure. That's a quote. Okay? And that study had multiple different medications that people were getting. And they clearly show of all this medication, beta blocker did nothing to lower somebody's blood pressure. And there were all these folks, okay, in Scandinavia. So, and the beta blockers, of course, are Enderol, Tenormin, Corgard, Timolol, Lobatalol, Viskin, etc. Okay, now, of course, there are much more, many more beta blockers than that. And then next week, I'll take the time to explain to you how they work and in what condition they work and when to use them, but never as monotherapy to treat blood pressure. Listen, I'm going to stop here until I see you again. This is Dr. Alcena saying so long and bye-bye.